Okay. So this is a case of a dislocated IOL in which we were planning to fix the same same IOL, and you can make out that on the temporal side we have fixed the haptic already. It's a three-piece foldable lens. We have externalized the first haptic and it has been tucked already. Now we are going to do the externalization of the second haptic. As I have told, like unlike others where they externalize both the haptic and then they tuck, usually I just externalize one haptic and tuck it because I feel more secure because the lens will not dislocate once the IOL is tucked. So in this I am externalizing second haptic, and you can make out the mistake I have done. I have done a grave mistake, I can call it as. If you notice, I have held the shaft of the haptic. I have not held the tip of the haptic. Sometimes it happens, like I don't know, sometimes something goes wrong inside. So you do like this, I have externalized, and you can see the kinking of the haptic. If it is a hard lens, PMMA lens, the haptic is quite okay, nothing happens. But in foldable lenses, when the kinking happens, when we are trying to tuck, if you are fortunate, it doesn't break. If you are unfortunate, it breaks. So what we are doing is I am just checking the patency of the groove and inserting the haptic with the help of the forceps. Now I am very cautious holding the tip. When I am inserting, yes, I have inserted, but still I am not very sure because you can see after some time the optic is slightly going posterior. When I went inside, I can see the haptic there. Half of the haptic is broken. What to do in such cases? If the haptic is broken for 1 millimeter, it's fine. We can try to insert the same, but I don't take a chance because a second procedure is much worse than doing another maneuvering at the first procedure itself. So what I usually do is just expand the IOL. Doesn't matter. Even though the patient has paid for the lens, yes, we have to replace it. So remove the lens. If the haptic is more than 2 millimeter or 1 millimeter broken, don't ever take a chance, because even if we insert, there will be some decentration or with some trivial trauma, the haptic can break. So in this case, I have just removed the lens, and now we are replacing. Now I am very cautious. You can see that I am holding the tip of the haptic, not the shaft of the haptic. So because once I have suffered, now I am holding the tip. And as I told you earlier, being a posterior segment, I just put the trailing haptic into the vitreous cavity because for me, manipulating inside the vitreous cavity is much simpler. But in case of an anti-segment surgeon, you can do that. So again, you can see I am very carefully holding the tip of the haptic and just inserting. Now we go to the vitreous cavity. Again, what we have to do is the second haptic is, I'm going to hold the second haptic inside the vitreous cavity. Most of the time we can visualize the second haptic without any biome because it's quite anteriorly placed. With the focusing of the microscope, we can hold the haptic. And usually I close all the ports and use the second instrument in the left hand so that we can support the sclera when we are externalizing. Now it's externalized. Now again I am very cautious holding the tip and now inserting the haptic into the groove. The IOL is well placed. So this is a very common mistake when we do. The first thing is don't ever hold the haptic at the body. It should always be held at the tip. And with slight kinking, another problem also happens. Even if there is no snipping of the haptic, if the kinking happens, when we insert, there is always a decentration of the lens, a tilting of the lens. To avoid that, if the haptic is broken, just don't bother, expand the lens and go for a fresh lens. Thank you.